Now we're on to intubation, where the name of the game is think ahead. Before you actually embark on the intubation, you might want to think of a few critical questions. 1. What is the likelihood that I will be able to easily intubate this patient? Risk assess. What will I do if it doesn't work? Weigh the risk-benefit of RSI. How can I make this easier for myself? And how can I make this easier for my patient? Let's start with, what will I do if it doesn't work? Well, it's good to have your bag valve mask available if you can't get the patient intubated. You should have already considered before you start whether the neck is cricable. You'd want to have an LMA easily accessible. You want your bougie at the ready. All your airway toys should be plugged in and accessible. You should have backup if there's another physician that could potentially help you if it goes wrong. Might want to let them know what's going on so they're ready to assist you. What is the likelihood that I will be able to easily intubate this patient? Some of the things that go along with this are they easily oxygenated? How high is their pre-attempt CO2? Let's consider the body habitus. Are they remarkably obese? When you lay them down, will their soft tissue in their oral pharynx, their neck, their chest, and their abdomen impede respirations to the point that they actually arrest? How about the airway physiology itself? Did you look inside their mouth already? Check the length of their neck? Short necks suck for intubation, so you might want to actually assess that before you get in there. What about jaw laxity? Can you actually open and close the mouth? How about neck mobility? Is this somebody who could potentially have a cervical spine problem? Do they have rheumatoid arthritis or something that actually could get in the way of the intubation? Are they super old and super stiff? Is the cricothyroid membrane accessible? How big is their neck? How about cardiac function? To get through an intubation and through RSI, it's nice to have good cardiac function. If the cardiac function is impaired, you're likely to run into trouble. How about volume status? Is the patient super dehydrated? When you give the drugs, they'll have a greater effect and potentially cause problems if that's the case. Consider the volume status. How about equipment failure? It's good to know that all your equipment works before you start. RSI. Something to consider. Do you really need to sedate and paralyze every patient you're going to intubate? What's the best sedation for this particular patient? For instance, ketamine is a bronchodilator. Patients can still breathe effectively when they're on ketamine. This might be a nice adjunct for you. Is paralysis truly necessary? If it's going to get you through the intubation and get the patient intubated quicker, well then, yes, it is. If the patient is extremely fragile, sometimes paralysis makes them worse and it's potentially harmful. Just stop and think about it before you start. Risk assess. How about adjuncts? Consider pain management during intubation. Push dose pressors at the ready. Lidocaine is sometimes necessary. Think about these things before you start. How can I make it easier for myself? Well, clearly it's been shown that you buy yourself time if the patient is oxygenated before the intubation is attempted. Nasal cannula is helpful and 100% non-rebreather as well. It's best if the patient is sitting upright, sucking air. That is physiologically the best possible way to breathe, is sitting upright, lungs expanded, sucking air. Positive pressure ventilation is actually fighting to get the air in at all times. So if you want to make things easier, have the patient pre-oxygenate themselves sitting upright. Add to that some CPAP or BiPAP, and you are very likely to get any patient pre-oxygenated before you start. Here's some other ways you can make things easier for yourself. Positioning. The picture on the left shows you the ear to sternal notch. You want these two points on the body to be level, and the person should be facing upwards with their face parallel to the ceiling. This is the optimal position to get someone intubated. Sometimes it requires ramping the patient up to make that happen. You might want to consider the space between the hyoid and the thyroid. There should be 2 finger breaths there. If there's not, you have a short neck and the potential for problems. In that case, you might need to adjust your equipment. The airway will probably be significantly more anterior and a little bit more difficult to access. When you're intubating, manipulating the airway with your right hand when you can't see it easily can be very helpful. Having an assistant do it can be as harmful as it is good. And it's rarely truly beneficial. But if you do it for yourself, it can make a big difference. Lead with the sucker. Pull the jaw out. Put the laryngoscope in. Doing this before you approach them with the laryngoscope, taking the jaw, pulling it up and out, gets the tongue out of the way and gives you a place to put the laryngoscope. The laryngoscope easily inserted, you follow with the suction, making sure that you can see the epiglottis and then the airway. Having the suction first is very helpful, especially when there's secretions or high potential for vomiting. If the patient does vomit during the intubation, 2 things you can do. Lift the head up using the laryngoscope. This makes all the vomit pool lower and the airway stays in view. Also, you put the suction in the esophagus. This also helps to keep the fluid out of your way so you can see the airway. If you lift the head up with the laryngoscope as well as put the suction in the esophagus, you should have a good view. Using a bougie for intubation is also very helpful. When you use a bougie, you can actually see the bougie go through the cords because the relative space between the bougie and the size of the cords, bougie small, opening big. Anytime you do intubate with an ET tube, at some point you are going to obstruct your view. So it's hard to say that you really saw the tube go through the cords. You saw the tube go up to the cords, but you actually rarely see them go through the cords. This is not true with a bougie. You will know you're in. Some preparation before you start. Did you ever hear the ample approach? Questions you might want to ask the patient. Are you allergic to anything? What medications do you take? What is your past medical history? When was your last meal? These are questions that can be helpful before you intubate. Knowing that the suction is functional, that's a tongue twister, is really helpful. You want to make sure you have the yank hour. If someone vomits and you have the yank hour in the mouth and it's not suctioning well, quickly remove the yank hour and just use the tubing. The opening is much larger than the tiny little holes at the end of the yank hour. If that doesn't work, you can actually suck water through the tube and then put it back into the airway. That removes the thick stuff that's within the tubing. If neither of these things is effective and the patient doesn't have a neck injury, you can quickly dump the head, remove the vomit, and then reinsert the suction into the airway into the esophagus so you can intubate the patient. Airway assessment should include looking whether the patient has dentures. It's very frustrating when you go to intubate a patient, you haven't looked to see if they have dentures, and as you go to intubate, the dentures fall in your way. Best to assess this ahead of time. It saves frustration. Always pre-oxygenate the patient. Make sure respiratory is aware of what you're going to do. Make sure the staff that's working with you knows what their roles are going to be. Have a contingency plan in place. This is like a talisman. It wards off problems. If you say, I'm going to intubate this patient, I'm going to use these tools, I'm going to make 2 attempts. If I don't succeed with those 2 attempts, I'm going to move on to either cricothyrotomy or LMA, depending on the patient. If everyone in the room knows what you're planning to do, they can facilitate the transition. This makes it a lot easier for you and them. Less chaos. Make sure the monitor is visible. While intubating a patient, the heart rate should truly never be below 100. Anybody who's in respiratory distress should typically be a little bit tachycardic. If during the intubation, the heart rate starts to go down and goes into the double digits, it is concerning that patient is retaining CO2 and about to arrest. Keep that in mind and make sure that you're able to see the monitor while you're intubating. Have your bag valve mask available. Once you bag and then go to intubate your patient, don't drop it on the floor. Keep it near you so that you can use it again if necessary. Make sure all your toys are ready, plugged in, make sure they work, make sure they're on. Make sure you have a tube in different sizes. The size you want, and one smaller is usually effective. Put the stylet or bougie into the tube. It's significantly easier to intubate when you have a stylet than a floppy tube. Make sure the balloon works. What will happen is you'll have the hardest intubation you ever have in the world